y'all. All right, so we are going to do a little thing. Usually I have somebody, let's go back. Okay, usually I have somebody help me from the audience, but since we don't have an audience, Allie has to help me. So Allie is the chest wall. I am the lung. Okay, I'm the lung, she's the chest wall. Here is the pleural space right here. Now, I don't have any muscles or nerves or anything like that, so I'm not going to move unless she moves because I'm attached to her. And I'm attached to her by negative pressure. Okay, there's negative pressure. So when she moves to the right, So when she moves to the right, well, that's my right. I have to go with her, so go to the right. All right, I have to go with her, right? I go the other way. Push me. There we go. Okay. See, I have to go wherever she goes. Go that way again. Oh, okay. Okay, good. Okay, so now let's go back here. All right, so I have to go wherever she goes. She's the chest while our dogs are jumping up on us while we do this. Okay, so now let's say I get knifed. We get knifed. The knife comes right here. And we lose negative pressure. We're not attached anymore. She doesn't move. I move. And I go. Now go to your right. See, I'm not going with her. Go the other way. Okay, see, I'm not going anywhere. So what we have to do is we have to put a tube right in here, right into the pleural space. We're not putting a tube into me, putting a tube into the pleural space. And then we attach it to suction. And it goes to suction and I go. And I reattach by negative pressure, so go that way. Oh, and now I'm going with her again. Go this way. Oh, and I'm going with her again, okay? So what is the purpose of a chest tube? Purpose of a chest tube is to reestablish negative pressure. Thank you, Allie. You're welcome. Okay, so that's the purpose of a chest tube. Now I'm going to move my camera down a little bit. All right, that's fine. Okay, so the purpose of a chest tube is to reestablish negative pressure. Let me share my whiteboard again. Okay, so let me write that out. Purpose for a chest tube is to reestablish negative pressure. To reestablish negative pressure. Now, in a pneumothorax, the chest tube removes air. And in a hemothorax, the chest tube removes blood. And in a pneumohemothorax, the chest tube removes air and blood. All right? Here so you can see it a little better. All right, now you can have up to 4 chest tubes because you have one chest tube. If you have, let's say you do get knifed and you get air and blood into the pleural space, you can have a chest tube for air and a chest tube for blood. And if you have bilateral lung collapse, you can have up to 4 chest tubes, okay? So location of the chest tubes. The first one is apical. Apical is high for air, so it's high up on the. If you think about where it's at, if you looked at the actual patient, it would be higher up on the back. And the second B2 is basilar. Basilar is low for blood. So a basilar chest tube is for a hemothorax, and an apical chest tube is for a pneumothorax. All right, now, how many chest tubes? I'm going to open up my chat so I can see what you guys are saying. Hold on. All right, how many chest tubes? 1, 2, 3, or 4. How many chest tubes and where for a unilateral pneumothorax? How many chest tubes and where for a unilateral pneumothorax? Okay, yes, it's 1 chest tube. And if it's a pneumothorax, then it's an apical. 1 apical. All right, the next one. How many chest tubes? 1, 2, 3, or 4. And where for a bilateral pneumothorax? How many chest tubes and where for bilateral pneumothorax. Correct. There's two. There's two, one on each side, and they're both apical. How many chest tubes and where? 1, 2, 3, or 4 for post-op chest surgery? Now, this is a little bit of a trick question. So they will not do chest surgery bilaterally unless they absolutely have to, because nobody wants to collapse both of your lungs. So if they say chest surgery, you are allowed to assume it is unilateral. They have to say it's bilateral or it's not bilateral, okay? So if they say chest surgery, you are allowed to assume it's unilateral, but you're cutting into the chest wall. You're cutting into it. So you know air and blood are both going to get in there. So how many chest tubes? There's going to be two. One is going to be apical and one is going to be basilar. Okay. All right. Next question, problem solving. So let me just, I'm a picture person. So let me just quickly just kind of draw it. Some of you probably haven't worked with chest tubes very much. And so I'm just going to kind of draw it. So here we have the chest tube. Okay. So the chest tube is coming out and it's coming into this device, this chest tube device, and it goes into what we call the water seal chamber. Okay. And then on this side, it's going to suction control chamber. Okay. And at some point in here, there's a place that you can collect blood. Now, this is current. This is the current chest tube model. But let me talk old school just for a second. Where exactly are they placed? You mean on the body? So if you're looking at someone from the back, okay, here's their ribs. This is their back. All right. Usually, if it's apical, it's up here somewhere. Now it doesn't, it's coming in up there. And then if it's basilar, it's usually down here somewhere. Okay. So that's what I mean by high and low for apical and basilar. That's looking at them from the back. Usually that's where they're at. Okay. Now let's talk about old school chest tubes just for a minute, because they've had chest tubes. They've been doing chest tubes for hundreds of years, like no lie. They've been doing chest tubes for hundreds of years. But they were old school chest tubes. So here we have our chest tube and it's coming out. And the way it always used to be was it would actually go into this glass bottle. And the glass bottle would actually have water in it. Because what is the risk when you put a tube into someone's pleural space? Okay, you put a tube in there. What is the primary risk? And it's not infection, so don't say infection. What's the primary risk if you put that in there? Well, the risk is that it's going to get air back in there, right? We don't want air to get back in there and make that even bigger and a problem. So we don't want air to get back in there, but we do want air to be able to get out, and we want blood to be able to get out. So how do we make this one-way valve that allows air to leave but not come in? And what they found was the best way to do that was actually to put the end of the tube underwater. So you'd put the end of the tube underwater here. And so air could leave, bloop, 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 right? Air's leaving. And blood could leave, but no air can get back in. So we call this a water seal. So that's old school. It was like literally a glass bottle on the floor that had water in it and the tubing just went under there. Now the problem was eventually that lung would re-expand because eventually all that air and blood would leave just by gravity, right? Just gravity. The person's above the level of that glass chamber. That glass chamber had to stay on the floor. And so by gravity it would leave, but it would take a long time. Like sometimes people would be in hospital for weeks waiting for their pneumothorax to re-expand. So what we realized is if we could attach it to suction, we could re-expand this a whole lot easier. And so the person, it actually doesn't require gravity anymore. We still keep chest tubes containers on the ground, but you don't even have to. Like they could pick them up and walk if they want to. You can disconnect them from the suction so they can go to the bathroom and then reattach it when they go back to bed or whatever. Even if they want to walk in the hall, they can reattach, disconnect it from the suction. Just remember, I mean, for hundreds of years, we had no suction on these things. As long as they keep the chest tube, hang it below, they can hold on to it as long as it's not like up here somewhere. They don't have to be attached to suction 100% of the time. But what we found is if we attach it to suction, it will re-expand the lung in days, a few days rather than a few weeks. And so what we have now is we still have, and they have to put the water in when they open the package, but there's still a little bit of water in here. Okay, there's still a little bit of water. You got to kind of get down there and look at it. But there is. Now, up until about 10 years ago, they also had water in the suction control chamber. And what they did is they would turn on the suction. Okay, they turn it on to continuous. And by turning it on to continuous, they would see the bubbling in this water. So let's say there was this much water, and this represented 10 centimeters. This was 20 centimeters, and this was 30 centimeters. And they would turn the suction on until the bubbling got up to wherever they wanted it. Right? The bubbling was going up to here. And that's how we determine centimeters of water pressure. So that's up until about 10 years ago. That's the way these things were hooked up. That's not the way they make them anymore. So I don't know if you're going to get questions about bubbling in the suction control chamber. I am sure there are still places in the United States where they have these chest tubes that have water in the suction control chamber. We still have water in the water seal chamber. I don't think that will ever change. And you can still have bubbling or no bubbling in the water seal chamber. But most of you are going to work with chest tube devices that do not have water in the suction control chamber. However, last we knew about it, they were still asking questions about bubbling in the suction control chamber. Okay, so just knowing that, let's go ahead now and talk about this. So let's talk about problem solving. I'm gonna just make this just a little smaller for you in case anybody wants to look at it while I'm still talking. Okay, all right. So let's talk about problem solving. What do you do if you knock over the collection device? And this is the collection device. Well, what happens if you knock it over? You pick it back up. I know this is why you paid big bucks to take this review, but this the reason we tell you this is because it's easy to overthink, right? It's just easy to overthink and to be like, oh, I don't know, what if I knock it over? It's like the end of the world. Nope, just pick it back up. It's not the end of the world. What do you do if the water seal breaks? Okay, go ahead and turn the page because the answers are on the next page. So page 18. What do you do if the water seal breaks? Now let's talk about this theoretically. Let's go back to the old school chest tube. What do you do if the water seal breaks? Well, what was the purpose, old school? What was the purpose of a water seal? What was the purpose of the water seal? Well, the purpose was to prevent air from getting in to the pleural space, right? That was the purpose of the water seal. So even though it looks a little bit different, what is the purpose of the water seal today? The purpose of the water seal today is still to prevent air from getting back in. It's still a purpose. The purpose has not changed, even though it looks different. Now, let me tell you something. This is a theoretical question because I have never had in these new devices, I have never seen the water seal break ever. I mean, you would have to yank it really, really, really hard for that to happen. I mean, step on it, crush it, roll over it with a dump truck. I don't know. I've never seen it break. However, in the old school chest tubes, the water seal could break pretty easily if that tubing got yanked out. So they still have these questions on NCLEX, interestingly enough. They still will say, what happens if the water seal breaks? So don't think, well, how would that happen? Don't think that. You have to think theoretically, and you think, well, if the water seal breaks, what's the concern? I don't care if it could really happen or not. What is the concern? The concern is that we're going to get air back in. So we're going to talk about what do you do first if the water seal breaks. Okay, so here's what you do first, second, third, fourth. Alejandra says, I'm from Mexico. We don't have the same equipment than the States. And they told me that if we knock the collection bottle we'll have to call the healthcare provider because of a pressure change. No, not if you're taking the US. The US NCLEX will not be that. That will not be the case for the US NCLEX, Alejandra. In the US NCLEX is going to be pick it back up. Okay, so first, if the water seal breaks, you're concerned that the air is going to get back in, right? So first, you're going to clamp the tube. Then you're going to cut the tube, and you cut it most distal that you can. So if the water seal breaks, you're probably going to cut it like right here. Okay, that's where you're going to cut it, right? So you cut it. Now we're going to go old school, y'all. We're going to go old school. We're going to immerse it, the tube, in water. And remember, NCLEX is a perfect world. If you need water, it's there. It's at the bedside. Most policies say that if you have a chest tube, you're supposed to have a gallon of sterile water at the bedside. That's sort of policy. So the assumption is you've already got it there. And then fourth, you unclamp it. Okay, you unclamp it. So that's what you do. You clamp it, then you cut it, then you immerse it in water, and then you unclamp it. And I know you've only got one line. You kind of have to write it all there, figure it out, okay? So that's what do you do first. Now, what's best? Let's say they say the water seal chamber has broken. And what is your best response? And these are your four options. These are still your four options. Now, I want you to go back to the paper you wrote down yesterday. I told you we're going to talk about prioritization. And I said we had 5 strategies for prioritization. Do you remember that? And I said, write these down, maybe on a separate piece of paper or something like that. So I want you to go back to that piece of paper. And I want you to look and see where I said, I think it was the fourth option. And I said, we're going to learn how to answer best questions. And it's going to say what is best to do, not what's best to say, not what is best to assess. Well, could say what's best to assess, but it's a do thing. It's not like a speaking or a teaching or anything like that. It's what's best to do. That was number 3. Okay. So it was number 3 on that prioritization. This is the one we're talking about right now. Okay. So here the question is, what's best to do? And you say, well, I have to do them all. Like, how can I do one and not the other? Okay. So you have to remember these are theoretical questions. Theoretical, which means you are never going to be a situation in real life where you can only do one thing. But on the test, you can be. Okay, on the test, you can be in a situation where you can only do one thing. So that's why it's a theoretical. And what they're always doing, these kind of best questions, what's best to do, these are always fundamental questions. Did you hear what I just said? They're always fundamental questions, because the only way they can say something is best to do is if it's a fundamental do or die principle. So when you get these best questions, you need to go, whoa, okay, I got to get these right. I got to get these right because, yeah, I can't answer that right now, Valbir. Ask somebody else in the chat. You got to say, I got to get these right, or at least not all of them. I got to get at least 50% of them right, because they're testing some kind of fundamental principle here. Okay, so I'm going to teach you how to answer these questions. All right, so first of all, what you do is you say, well, if the water seal broke and I need to decide what's best, I'm trying to prevent air from getting back in. So I always cross off something that I go, well, that's not going to help prevent air from getting back in. All right, so I'm going to say, well, cutting the tube is not going to help prevent getting air going back into the pleural space. And unclamping the tube is not going to help prevent air from getting back into the pleural space. So I'm down to 2. And I'm like, okay, what's best to do between these 2? So here's how you answer it. You say, and you have to use these words, I will do one, but I will never do the other. If you're taking notes, you write this down. I will do one, but I will never do the other. I will do one, but I will never do the other. You can't say I will do the other one later because that's first. That's a first question. First questions are in some ways are actually easier than best questions because first questions allow me to just decide what to do first and I can do all the other stuff later if I want to. But best questions, I can only do one. So here's how you do it. You take two at a time. You say, I'm going to clamp the tube, but never immerse it in water. Or I'm going to immerse it in water, but never clamp it. Now, the rule is that you cannot clamp a tube for longer than 15 seconds without a doctor's order. And that's later on in the lecture, so you don't have to write that down right now. You can't clamp a tube for longer than 15 seconds without a doctor's order because it can re-expand the pneumothorax. So even though clamping the tube is better than doing nothing, I'd rather clamp the tube than do nothing. Like, I don't want to just leave it hanging in the wind, right? But it's really not best to clamp the tube. And the reason I bothered to tell you that we used to always immerse it in water, old school was immersing it in water. So you go, well, yeah, obviously it's better to immerse it in water than clamping it, never clamping it, because it's fine. You can immerse it and walk out of the room. But I would not be okay with clamping it and then walking out of the room. I would not be okay with that. I'd be like, yeah, I can't do that. So the best thing to do is to immerse it in water. Okay? Now, what do you do if the chest tube comes out? What do you do if the chest tube comes out? Well, what are you concerned about if the chest tube comes out? The same thing you're concerned about if you water seal breaks. You're concerned about air getting back in, right? That's the big concern. You don't want air to get back in. So we got to do something to prevent that. Okay, so if the chest tube comes out, and that is probably more likely to happen than the water seal chamber breaking, because it can just get yanked out. Now we tape it up like crazy, so it doesn't happen. So it doesn't happen very often, but it could potentially really kind of happen. So what do we do first? Well, first we have to cover it with our hand. You might say, well, don't I have to wear a glove? Yeah, of course you do. But if it doesn't say wear a glove, that's okay. Like the assumption is, yeah, I got a glove on. It's a perfect world, right? Cover it with my hand, and then I'm going to cover it with Vaseline gauze. Now, Vaseline is a trade name, so they're not going to use the word Vaseline. They're going to use the word petroleum jelly. But the reason we can use Vaseline gauze is it's gauze that's impregnated with Vaseline. Because the weave of those little 2x2s or 4x4s, the weave is loose enough that air can go through, and we don't want that to happen. Okay? So cover it with Vaseline gauze, and then cover it with a dry sterile dressing, and then tape on 3 sides. So that's what you do in that order. Samuel said, just to clarify, if they ask what's the first, I would answer clamp. And if they ask what's best, I would immerse. That is correct. Catherine, they don't call Vaseline gauze occlusive. It is occlusive in that air can't get through it, but it's not occlusive. Occlusive dressings are taped all the way around. By definition, in healthcare, occlusive dressings are taped all the way around. So this would not be considered an occlusive dressing. It's a Vaseline gauze dressing because it allows air out, but doesn't allow air in. All right, now let's talk about what's best. So this is what you do first. Okay, this is the order for first, but let's talk about if they said what's best. They said the chest tube comes out, what's best? And they give you these 4 things. Cover with your hand, cover with Vaseline gauze, cover with dry sterile dressing, and tape on 3 sides. You go, well, what? I got to do them all. No, it's a theoretical question. What is the best way to prevent air from getting in? So let's cross off some answers that aren't going to help air get with the air thing, right? Taping it, just putting tape on the skin isn't going to help anything. Covering it with a dry sterile dressing isn't going to help anything because that's just going to allow air to go in. So I have to decide, is it better to cover it with my hand or cover it with a Vaseline gauze? So I'm going to say I'm going to cover it with my hand, but never cover it with a Vaseline gauze. So I'm going to stand there and stand there and stand there and stand there. Or I'm going to cover it with a Vaseline gauze, but never cover it with my hand. So I'm going to walk out of the room. It's just going to be covered with Vaseline gauze. Well, that's not ideal. I mean, it's not ideal to just cover it with Vaseline gauze, but I do know that Vaseline gauze is impregnated with Vaseline, so it will stick to the skin. It will stick to the skin. And I mean, I can walk out with it like that. It will cover it. And it's better than standing there with my hand over it the whole time. So I'm going to have to pick cover it with Vaseline gauze. That is my best option. Okay, the reason you don't tape on all four sides is the same reason you don't leave it clamped for longer than 15 seconds. Because if you tape it on all four sides, then no air can get out at all, and it can re-expand your pneumothorax, okay? So that's why you do that. Now, if you're like, I'm really struggling with this first and best thing. First means, what do I do first? What do I do first? I don't know how else to explain it. But when it says, what do you do first? It means I'm going to do all of them, but which one am I going to do first? So you're not trying to rule anything out. You're just trying to figure out the order. But when they say best, what's best? It means you can only do one thing. If you can only do one thing, what is best? Now, I've got a number of other examples to go over with you. So hopefully by the time we get done with these, you'll understand.